The next speaker is Serge Ouoba from Hiroshima University and Institut de Recherche de Sciences de la Santé from Burkina Faso. And he is giving a talk about hepatitis B infection prevalence, genotype, distribution, and knowledge of mother-to-child transmission among antenatal care attendees in Yako, rural Burkina Faso. Thank you.
Thank you, Mr. Chair. Thank you to the COLDA organizing committee for giving me the opportunity to make this presentation. I'm Serge from Burkina Faso, currently in training at Hiroshima University, Japan. And my presentation is on hepatitis B infection in pregnant women in rural Burkina Faso. There is no conflict of interest to declare. So Burkina Faso is a country in West Africa with a nationwide prevalence of HBV estimated at around 9%. Since 2006, the Burkina Faso government has implemented the pentavalent vaccination as part of the EPI at 2, 3, and 4 months. So far, we don't have any routine birth dose, and there is no routine screening of pregnant women. However, we have national guidelines for the prevention of mother-to-child transmission of HBV that were adopted in 2019, and these guidelines say that when the pregnant woman visits the hospital for antenatal care, she should be screened for hepatitis B, and if positive, irrespective of HBe antigen positivity, if the DNA level is greater than 2,000 international units per ml, she should receive treatment with tenofovir from 6 months of pregnancy until 3 months after delivery. In the case HBe-AG is unknown or HBV-DNA is unknown, tenofovir treatment should also be given. Baby should receive the birth dose vaccine, followed by the monovalent vaccine at 1 month and the routine pentavalent vaccine. We also know that the WHO has established guidelines in 2020 recommending to treat pregnant women with DNA over 200,000 international units per ml, or for those in case HBV DNA is not available, to use HBe antigen positivity as a criteria, and this in addition to the birth dose. The WHO guidelines were mainly based on studies that were conducted in Asian countries. Gaps have been highlighted, including lack in the African country and HBIG is not given to babies. So we are conducting this research. It's still ongoing, and it's a longitudinal study divided into 2 main studies. Study 1 is on the prevalence of HBV infection in pregnant women, and study 2, we are assessing the prevention of mother-to-child transmission by tenofovir in Burkina Faso. It's conducted in 3 healthcare centers. So in study 1, pregnant women are screened for HBV using a rapid diagnostic test. And those positive are given treatment by tenofovir from the 6 months of pregnancy until 3 months postpartum. And we are following them in study 2 at delivery 1 month and 6 months. And at each time point, blood samples are collected using dried blood spots. In study 1, we aim to know the prevalence and risk factors of hepatitis B and the distribution of E antigen and HBV DNA in the pregnant women. So I will now present the result of study 1, which is now completed, and study 2 is still ongoing. So a total of 1,622 women were included, and the mean age was 25 years old. Most of them were between 15 and 24 years. They were mainly housewives and had no to none or non-formal education. They were mainly plimiparous, and the HIV status was 0.4% among them. About the knowledge of HBV, when asked if they have ever heard of hepatitis B, 54% of the pregnant women said yes. Among them, 97.5% have never received the HBV vaccine. And the main reason for not having received this vaccine was because they didn't know about the vaccine. So this shows that the disease awareness is poor in rural Burkina Faso. About the prevalence of HBs antigen. Overall, we found a prevalence of 6.5%. The prevalence was lower in younger age groups, but it was not significant. For HBe antigen, the positivity of E antigen in the full cohort was 22.1%, and it decreased with age. It was higher in the younger age groups. When looking at the factors associated with HBs antigen positivity in pregnant women, age 25 to 34 years, multiparity, and importantly, female genital mutilation history were related with high prevalence of HBs antigen. So female genital mutilation is criminalized in Burkina Faso, but it's still being done, especially in rural areas. Regarding the distribution of HBV DNA was higher in the HBe antigen group compared to the HBe antigen negative group, and this was significant. When looking at the distribution by age, the HBV DNA was higher in younger age groups, and if we consider the WHO criteria of 200,000 international units per ml to decide for the antiviral prophylaxis, a total of 18.8% of the pregnant women meet this criteria. It was higher in the younger age group and decreased with age. So this is the procedure for the genomic analysis in order to identify the HBV genotypes. We have performed PCR targeting the surface polymerase region and the surface region of the virus, and in total we could, of the 102 DBS samples we could successfully perform the sequencing in 67 samples. And then doing the phylogenetic tree for the surface polymerase and the surface region, we found that the main genotype in Burkina Faso was genotype E, and it represents almost 2/3 of the circulating genotypes in the country, in this area. So the WHO recommends to use HBe antigen as a marker to decide tenofovir prophylaxis in pregnant women when DNA is not available, and this was based on a systematic review that found a pooled sensitivity of 88.3% and a specificity of 92.6%. However, few studies from West Africa were included, and genotype E is the most prevalent in West Africa. We hypothesized that the accuracy of HBe antigen to diagnose high viral load may be different considering the genotype. So in our study, we found a sensitivity of 53.8% of HBe antigen to identify high viral load. And reports from the Gambia already published have found that this sensitivity is 65.5% in genotype E, and it was higher in genotype A. It was 50%. It was 100%. So the HBe antigen accuracy to detect high viral load might be low in genotype E from our findings. So in conclusion, HBV prevalence in pregnant women in Burkina Faso, in rural Burkina Faso, was 6.5%, and HBe antigen was 22.1%. Genotype E is the most predominant, and we found a low a sensitivity of 53.8% for HBe antigen to detect high DNA level. HBe antigen is, HBV genome E is poorly studied, and we need evidence on the accuracy of HBe antigen to detect high viral load. Point of care viral load test and other seromarkers such as the hepatitis B core-related antigen might be required in genotype E. So I would like to acknowledge these people, and thank you.